Hey, everybody. Great to see you again. Welcome to our daily science recap from day 2 of the International Stroke Conference 2021. My name is Mitch Elkin, and I have the pleasure of serving as the president of the American Heart Association and American Stroke Association this year. And I'm joined this afternoon by Dr. Louise McCulloch, who is the chair of this year's ISC, also by Dr. Tudor Joven, who is the vice chair of the ISC, and by Dr. Peter Panagos, who's the chair of the Stroke Council of the American Heart Association. So today was a very interesting and fun day. I hope you guys all agree. So this morning is my first session. I took in the session on the review of comprehensive nursing recommendations.
Fantastic. Thank you, Mitch.
I think it's important to remember that stroke care is really a team sport. You know, all of our great devices and drugs can't do their magic without great nursing care. And recently, the American Heart Association and American Stroke Association came out with guidelines for nurses at multiple levels. So we heard about management of patients with acute ischemic stroke in the pre-hospital setting, as well as the emergency room. So Peter, I'm sure you'd be excited to hear about that. Then we heard about the care of patients at the level of thrombectomy and immediately afterwards in the ICU, something that Tudor is probably very familiar with. And then we heard about post-ICU care and pre-hospital discharge care. So really focusing on stroke transitions, to when patients leave. And I thought it was really interesting to see things from the nurse's perspective as well. And I learned a tremendous amount. So I hope people will check that out when they have time as well. Louise, what did you see?
It was a great day. I actually started my day with the debate from Jeffrey Saver and Patrick Lydon and others about TNK versus TPA. Certainly a lot of advantages to TNK, especially as we start looking at pre-hospital systems of care like mobile stroke units or transfers, because you don't have to have that hour delay that sometimes is needed in an ambulance because they won't take a patient with a drug dripping. So I thought that was super interesting. Peter, I don't know if you want to talk a little bit about that?
Yeah, is certainly the use of a much more convenient, easier to administer thrombolytic is something that I think emergency medicine has been waiting for and willing to embrace. How to operationalize that into individual hospitals and systems are something that most of us, I think, have been doing. And there's certainly some great, fascinating data that's come out of our folks in Austin, Texas, that have done this extremely successfully. We've heard a session today that talked about that. So as an emergency physician, if I can give something as a bolus and walk away and do something else with close management at the bedside by nursing, and we can do drip and chips, or kind of maybe that term goes away, we just do ship with really quick door in, door out. I think that has huge benefits, not only to streamline pre-hospital care, but from symptom onset to groin puncture time for transfers. And we heard some of that data today that really supports that.
I thought it was kind of interesting. I think when Raul Noguera was presenting the SHRINE data, and he focused on how we should be thinking about I think he said precision medicine for this issue of who should go for intravenous therapy before their endovascular treatment, and who should go to a primary center versus to a comprehensive center first. Larger stroke patients, perhaps those with big deficits, you might push them towards earlier mechanical thrombectomy and forgo the intravenous therapy. I think that's a really powerful idea, but obviously we need to get more data first, I think.
I agree, Mitch. One thing that I loved about this meeting is that we're finally starting to see systems of care, really high quality data on systems of care for stroke. And that, obviously the mobile stroke unit, RaceCat, was today a great presentation on the subgroups, the relevant subgroups in RaceCat. The IV versus direct to thrombectomy, which is essentially a systems of care issue. So that, to me, that's been sort of one of the the great novelties about this conference, that we're finally getting the results of these systems of care trials. From that standpoint, just a few words about the RACECAT trial that was presented today by Natalia Perez de la Osa from Barcelona. So as you probably know, the primary result was already presented, and it has shown that in all comers with a race scale of 5 or greater, which corresponds to about a 40 to 50, about 45% chance of having a large vessel occlusion, that there is no benefit, that the outcomes are completely equivalent, whether you go to your primary center versus the thrombectomy center, with the caveat that these are all patients who are essentially greater than 30 minutes away from a thrombectomy center, because it was considered not ethical to randomize the ones who were within, who were primarily assigned to a thrombectomy center, which is about 30 minutes. So today, Natalia's presentation today focused on really those relevant subgroups, the ones, okay, not that you have a RACECAT of greater, a race scale of 5 or greater, but do you actually have large vessel occlusion? And do you benefit more if you have large vessel occlusion from going directly to an endovascular center? And the answer was no, you don't. The outcomes are the same. By the same token, because we always, and I had the privilege of being part of this planning of this study, we always said, look, there's going to be some groups that are going to be prejudiced by this approach, i.e. the ones who don't have large vessel occlusion and are TPA eligible. And those are going to get in a delayed fashion to the endovascular center and are going to have worse outcomes. And that was sort of one of the main reasons why the RACECAT was done. And the answer is no. In patients who are eligible for intravenous TPA, despite a delay in intravenous TPA administration, the outcomes are the same. So that gets you to this, absolutely to this, there is no one size fits all. Each network will have to find the solutions that work best for their own realities and their own infrastructure.
I think that's a great point. And we were talking about this just the other day. I feel like the last few years have really been about extending the window as long as possible, right? With DAWN and DEFUSE, and how can we use imaging to get patients as far out from their stroke as possible. And this meeting seems to be a lot about figuring out how to get to patients as quickly as possible, how to shorten the timeline on the short end, increasing the likelihood of treating people within the golden hour, as Jim Grotta talked about with the BEST MSU trial, how to triage people with systems of care to the right place as quickly as possible. So it's a different part of the equation, but certainly a super important one.
Great. And it seemed very consistent across the 3 late breakings today about skipping IV TPA. Peter, I didn't know if you wanted to mention anything else about the other 2 trials.
About the Shrines and then Mr. Clean, no IV. Those trials, yeah, certainly both of those I found extremely exciting, though both of them, as designed, came from different populations. The Dr. Nagara Shrine study used SCIP and DEVT from Japan and China data, and then the Mr. Clean No IV with Professor Roos from Netherlands with his European colleagues from France, Belgium, and Netherlands. Really 2 different patient populations, bridge versus no bridge, on their way to thrombectomy, show that they were certainly not superior or not inferior. So in a systems, I think that's extremely important, because the Heart Association published a very important paper last week that looked at regional systems of care, breaking it down from rural to suburban to urban settings, and trying to come up with guidance on how we get patients where they are, what type of screening we do at local hospitals before sending. Do we treat? Do we do advanced imaging? Do we transfer? And these studies, though they weren't positive studies, I find them fascinating that they're extremely well designed from different environments that show what we all see. And I think Dr. Nogueira, as you mentioned, the idea of precision. I think detecting the right patient using the right technology and the right tools who's going to benefit from the right therapy. I think these studies today are really kind of leading us down that road. And that's what I found really exciting about the science today.
Yeah, me too. In our last few minutes, Mitch, I don't know if you want to mention a little bit about the atrial fibrillation study, which I found really fascinating from Dr. Schwam.
Absolutely. Thanks, Louise. Yeah, I think that this was the Stroke AF study, which was a Medtronic-sponsored study, but looked at detection of atrial fibrillation in patients with stroke. And we know that patients with unexplained strokes, right, cryptogenic stroke, ESIS, there's a high likelihood of finding atrial fibrillation afterwards. And the longer you monitor those patients, the more likely you are to find AF. And previous trials showed the benefit of using an implanted monitor or more prolonged monitoring of some type to detect atrial fibrillation in patients with ESIS. But what Stroke AF did kind of turns that whole logic on its head, in that they looked at patients with non-ESIS stroke, so atherosclerotic stroke and lacunar stroke, the other TOAST categories, and found that there's, first of all, a rather high detection rate for atrial fibrillation, and that if you use an implanted monitor, you're much more likely to detect AF than if you don't. So it's about a 12% detection of atrial fibrillation at 1 year with an implanted monitor versus only 2% without an implanted monitor. So, very interesting that it's not just ESIS patients who have a lot of atrial fibrillation, but essentially all stroke patients who do. And in fact, there was no difference between the atherosclerotic and lacunar stroke subtypes, as Dr. Schwam showed. My lingering question about this, though, and I'm curious what you guys think about this, is, yeah, we can find a lot of AF in ESIS. We can find it in other stroke patients. But, we can find a lot of AF in people who are, the age of stroke patients who have stroke risk factors. So, for example, in the REVEAL AF study, which was another Medtronic trial, they showed about a 27% 1 year detection of atrial fibrillation in patients who had a CHADS-2 VASc score of at least 3. So, there's just a lot of AF out there. If you look for it, you're going to find it in ESIS, in other strokes, and in people who haven't had a stroke too. That's what I wonder. Maybe we just need to be monitoring everybody.
When I watched the presentation, I mean, I agree, Mitch. The thought that went through my mind was, is this the new EKG? I mean, just like we do routinely an EKG in everybody, is this the new EKG? Are we gonna have, or it's gonna be justified to do a long-term implantable monitor in everybody? And I'm not sure that the answer is not yes. Of course, the missing link here is whether if you have a bit of AFib, whether you benefit from anticoagulation.
Yeah, that's the important question, right? Is it going to change your management? Will it change you from a dual antiplatelet on discharge? Will it, keep you better linked in? No pun intended, to your physician, so you can, if it's detected, get on anticoagulation. I think longer term studies are really going to be important, looking at recurrent stroke risk in these patients with TIA or stroke, whether they have lacunar strokes or atherosclerosis. And I think because these monitors are so durable, the battery life is 3 to 4 years, I think we're going to get a lot of important information about not only what the rates of AFib are, but what are the rates of recurrent stroke, and should we be more aggressive in short runs of AFib anticoagulating? I don't know. Anticoagulation has its own downsides. So it's going to be, I think we'll see it in ISC 2022 and 2023.
Couldn't agree more. Well, thanks everybody for these great comments. Really enjoyed this afternoon's discussion, and look forward to doing it again soon.
Great. Thanks, Mitch.
Thank you, Mitch.